Good afternoon, everyone, and welcome to this patient-focused webinar. My name is Dave Burns from Insight Tech, and I'm pleased to be a part of today's virtual educational event. Please be patient as we're going to take a few minutes to allow everybody that's registered to get signed on. We will begin here in the next minute or two. Thank you. Very nice. Looks like we have a great number of folks signed on, so let's begin. First and foremost, I just want to thank each and every one of you for your concession of time. Certainly grateful and appreciated on this end. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. Greg Bonnen from Houston's Physicians Hospital located in Webster, Texas, as he discusses focused ultrasound as a treatment option for patients diagnosed with essential tremor or Parkinson's disease. As questions arise during the presentation, please utilize the Q&A button located on the bottom of your screen to submit. We will have time after the presentation to answer the questions that are asked within the chat. So please take advantage of this because your question is certainly a worthy one. I want to begin by introducing you to today's presenter, Dr. Bonnen. Dr. Bonnen is a board certified in neurological surgery by the American Board of Neurological Surgery and a fellow of the American Association of Neurological Surgeons. Dr. Bonnen serves as the chairman of the board of Houston Physicians Hospital. He grew up in Angleton, Texas, and graduated cum laude from the infamous Texas A&M University with a Bachelor of Science degree in biochemistry. He earned his medical degree at the University of Texas Medical Branch Hospital in Galveston, Texas, where he also completed his internship and residency. There he served for 2 years as an assistant professor of neurosurgery. Welcome, Dr. Bonnen, and thank you for your time today. The floor is yours.
Well, thanks, Dave. I appreciate it. And so we're going to go ahead and jump right in. I think the first thing you see here is just some of the things that we're going to cover. So we'll talk about a little bit of background. In other words, what essential tremor is and some of the statistics about how common it is. We'll go over what focused ultrasound is all about and a little bit about the technology and how it works. Then who's a good patient that could actually benefit from having this done. We'll talk about some of the outcomes, the results that we're getting. We'll discuss what you could expect if you were going to have the treatment. And we'll talk about insurance and Medicare coverage. And then the question of being able to treat the second side or both the right and left side. And then, of course, we'll have plenty of time for questions. So let's talk a little bit about essential tremor. It's also sometimes known as familial or idiopathic or benign tremor. And that means a couple of things. One is that there's no known cause. So we don't understand completely why people will develop it. But the other important element about essential tremor or familial or idiopathic or benign tremor is that it doesn't progress into a different type of medical problem. So it doesn't become Parkinson's or some other type of neurologic disorder. Now, the tremor can still progress to the point that it becomes debilitating, but it doesn't extend into other symptoms. So How widespread is it? Well, it's estimated there are about 10 million people in the United States living with essential tremor. And it's really very common, in not only my experience, but the experience of other doctors, that people just choose to live with it. And even though they get to the point that they can't write their name or sign a check or have trouble drinking out of a cup or dressing themselves, quite often they'll simply not receive treatment. And then when they do, the medications that we use to try to treat this are unfortunately often just not very effective. And so either they don't work very well, which is almost always the case, or even if they provide a little bit of relief, a lot of the time they have side effects that make it really almost worse than having the tremor. And so as a result, it's really frustrating to try to be treated with medications. So this gives you an idea of just the overall size of the population, and this slide's probably more geared toward other physicians who are wondering about how large the patient population would be. But as you can see, it involves a very large number of folks that have essential tremor. And then on the right side, there additionally are about another million people with Parkinson's who also could benefit from focused ultrasound. So we talked a little bit about a lot of the time patients, when they do seek treatment, will be treated with medication, and that can often be pretty frustrating, either because it doesn't work well and or there are side effects. Wearable devices are becoming more commonly used as a way to try to manage or offset the tremor. And then procedural interventions have been around for a number of years, and a lot of the time people are surprised to learn that we've actually been targeting this one specific location in the brain called the thalamus and doing a surgical procedure since the 1950s. But what's changed over the years is the technology, obviously. And so we've used different types of technology to try to target this same area that it was discovered could really help to reduce a patient's tremor. And when I first started doing this type of work in the 1990s, we were still doing what we call thermal ablations. So we'd make an incision, drill a hole, put a radio frequency probe down to the target and heat the tip of it up and then take it out. In the early 2000s, we began doing what we call DBS, and you can think of deep brain stimulation or DBS as a type of pacemaker for the brain. So it's very much the same type of technology, in that high frequency electrical stimulation can create a very similar or identical effect to being able to knock out that little population of cells, which is what we were doing with thermal ablations. DBS is still really common. I still do it. Many doctors are still using that technology. For some patients, it may be a really good option. It can provide some advantages in that it is programmable and can be adjusted over time. It's reversible. Also, you can treat both patients with Parkinson's that are FDA approved and accessible. The downside is that it's invasive, so it does carry a little bit more risk, even though I don't personally consider it to be really high risk. And many patients are simply not going to allow you to do that. And then on top of that, in an older population where you have patients that have a lot of other medical problems, a lot of the time the anesthesia risk becomes significant, and then they're not a good patient for that. So this is really where focused ultrasound comes into place. This allows us to do a thermal ablation like was done in decades gone by, but literally without any anesthesia, without making an incision, and without placing any type of mechanical probe or implant into the brain. And not only has it proven to be extremely effective for many, many patients and extremely safe, but it's opened up an opportunity for a majority of patients with essential tremor to be treated when in the past they would have simply elected not to have any kind of a procedure done. So we'll talk a little bit more about focused ultrasound. And, this is just a timeline of some of the milestones. So another common question that we get is, well, how long has this been around? How long has it been in development? And, what you can see is that back in 2016, the FDA approved it for treatment. And at that time, it was approved for treatment on one side. Another really big milestone was in 2018 when Medicare decided to cover it. So as you can imagine, it's great if the FDA approves something, but if there's no insurance or Medicare coverage, then it's still something that most patients aren't going to be able to access. With Medicare coverage, that means most patients are able to get it, plus Medicare is the trendsetter. So then you typically see the commercial insurance carriers follow suit. And that's where we are today in terms of insurance and Medicare coverage. Then in 2018, it was approved for treatment of tremor dominant Parkinson's disease. And in 2022, we received approval to treat a different target location in the brain that can be very helpful to patients with Parkinson's. The opportunity or ability for us to treat a patient's second side was approved in 2022. And so we have to wait 9 months or longer between doing a second side, but we're now able to treat both sides in the situation where a patient maybe has really severe tremor, not just affecting one side of the body, but both sides. And then there was approval of 5-year data or outcomes back in 2023. So as you can see, it's been under development and has gone through a number of major milestones over the last 20 years. So how does this actually work, or what are we doing? The patient is awake. It doesn't require sedation in any way. We do the procedure in an MRI scanner, and so it joins the technology of MRI, which allows us to look at imaging and also measure temperature with an ultrasound transducer. And this is a semicircular or kind of helmet-shaped device that has 1,024 little channels in it that will each emit a sound wave. And for any given procedure, we usually have somewhere between 950 and 1,000 of these little elements or channels are on. And no single channel actually generates enough energy to do too much, but where they all meet in the exact same location, it deposits heat. And we're able to control the location, the amount of heat, and the duration of the heat. And that is essentially what we're doing with focused ultrasound. So it's a really elegant, very sophisticated way to do what used to be done by making an incision and drilling a hole and putting a mechanical probe that we could heat the tip of that up when it was in the brain and then take it out. This way, there's nothing invasive, and we can still generate a thermal ablation at the same target site. So who qualifies to be treated? There are some parameters that we look at. And first of all, the patient does need to be diagnosed with either essential tremor or tremor dominant Parkinson's disease. Another is that there is a minimum age of 22 years for essential tremor, 30 years for tremor dominant Parkinson's disease. And of course, most patients are much older than 22 or 30 years old, but on occasion, I have seen some patients that are in their 20s or 30s. The patient has to be able to tolerate the procedure without sedation, but again, in my experience, we haven't had a patient yet that couldn't tolerate the procedure. So fortunately, that's not an issue. Uh, you'll see here it says be able to communicate sensations during the procedure. And what that means is that when we're doing the treatment, we'll come in throughout the course of the treatment and we'll actually talk to the patient, ask them, are they feeling anything, any numbness or tingling, or what did they feel during the last treatment? And we'll have them draw circles or spirals, as many of you have done, straight lines, and even write their names so we can track the progress of their improvement during the course of the treatment. And then they have to be able to squeeze a little ball that can actually stop everything if for any reason they have a concern or experiencing something that bothers them. That's extremely rare that anybody would need to do that. But as a precaution, we want them to be able to stop and let us know if they're having any kind of a problem. So what are the reasons that maybe somebody wouldn't be able to do it? For one, you have to be able to go into an MRI. Now, the good news is, even though many patients have different types of implants in their body, it's very unusual these days that the implants are not MRI compatible. And so even most pacemakers today can go into an MRI. They may require that we put the device into an MRI or safe mode, but it's pretty unusual that we run into somebody that has a medical implant that prevents them from being able to go into the scanner. Perhaps the single most important thing that we have to evaluate is just how well the ultrasound energy is going to be able to transfer across the skull toward the target. And we've got a calculation, something called a skull density ratio, that allows us to get a good measure of how efficient the skull will be with the ultrasound. It's not the only factor that contributes to efficiency, but it's the single most important one, and it's the one that we look at. So the FDA actually has established a threshold of 0.45 plus or minus 0.05, meaning the skull density ratio really needs to be 0.40 or above in order to qualify as being an on-label use of the treatment. Now, if the skull is too inefficient, the concern is not that it's dangerous in any way, but rather that so much of the ultrasound energy is going to be blocked out, we just won't be able to be very successful at making a lasting improvement. There are other variables that we look at when we're looking at a CT scan of a patient as a screening tool before the procedure, but the skull density ratio is the biggest one that we take a look at. And I would say about 95% of our patients meet this criteria, but once in a while we do come across someone that does not. So how many procedures have been done? And this isn't the most updated data, but the take-home message that you can see are really two things. We've got many patients, well over 12,000 now, that have been successfully treated. And actually, you'll also note the second piece of information, which is this is becoming an increasingly common procedure. So the volume of patients being treated in any given year is rapidly increasing, and that's simply because it's a new technology. And just a few years ago, there were not many facilities that had the equipment or were performing the procedure. And as it's becoming more commonplace, it's more available to patients, and we're simply seeing patients with greater access and better able to have this treatment done. And so the volume of our experience is increasing significantly. Across the world, obviously, the numbers are a little bit greater, but nonetheless, you see that the number of patients treated in any given year is growing. So what would you expect if you were to actually have this done? So it's outpatient, and what that means is that you're not admitted to the hospital either the night before or after the procedure. So the patient would come in on the day of the procedure, and we do shave the patient's hair. The reason for that is the hair will interfere with our ability to successfully perform the treatment. Now, there's nothing about the ultrasound that will in any way impair hair growth, and so it grows back just the same as if you'd had a short haircut. But we do have to shave the hair in order to do the procedure. We will then take the patient to the MRI scanner, and we attach a frame in the scanner area. And the purpose of the frame is simply to see that the patient's head is perfectly still when we're doing the procedure. And we've never had a problem with movement during one of these procedures. And a lot of the time people get concerned about their tremor, and they say, well, gosh, my tremor is so bad and I have head tremor and I don't know how I'll be still. The frame takes care of that for us, so we don't have to worry about movement and the accuracy of our targeting when we do it. The planning and the actual treatment itself takes about an hour to do the whole thing, sometimes a little bit less. Occasionally, it might be a little bit more. And this is all done within the MRI suite. In the beginning phases of the treatment, we'll do one or two so-called sonications or treatments just to look at the initial effect. In other words, we're looking to see, does the tremor get better? And we're looking to see, are there any side effects from that? And based on that information, we can make some adjustments. And then we'll do a couple more sonications to make the improvement permanent. And during the course of all of this is when we'll come in and we'll not only visit with the patient, but have them redo the drawings and hold a bottle of water and just do exam to see how they're improving with their tremor. So not surprisingly, the benefit is immediate. We can actually see the improvement with the patient lying on the scanner in real time. The sonications themselves, by the way, are really brief. So a short sonication would be 11 or 12 seconds, and a really long one is close to 30 seconds. And typically we'll do three, four, maybe five of them in the course of a treatment. So the actual time that the sound trans or the ultrasound transducer is on is literally seconds for any given treatment. The patient's able to go home the same day. So after the procedure, you'll go back to a room. The nurses will check your blood pressure and heart rate, bring you something to eat or drink, and then within less than an hour, typically people are able to leave. We have not had any infections to report in our experience of almost 500 of these. As already mentioned, there's no implant, there's no anesthesia, and there's also no radiation. So this is ultrasound. It's not a source of radiation. And this is just a little bit of a example of before and after, even on the same day of treatment. The immediate effect that you can see from or the results of the focused ultrasound thalamotomy. So I already talked about this a little bit, but just to kind of go back over whether this is covered, Medicare covers it, and most of the commercial carriers also cover it. So it's pretty unusual that we would run into a situation where a patient's insurance was an issue. But anytime that we're talking with somebody about scheduling, we always verify whether this is covered. And of course, if there's any cost share, be it a deductible or copay, we also determine or find out what that's going to be so that people know upfront any costs that they would incur. And then with respect to doing the second side, that's also become commonplace now and is covered by insurers. And there's a little bit more information we can share about the second side. When I first started doing these, the FDA hadn't yet approved doing the second side. So this was a bigger question, and we didn't have quite as much experience. So a clinical trial was done, and it basically proved a couple of things. One is that the second side can be done safely, and two, it can be done effectively so that patients benefit from having it done. The requirements are not unlike what they are for the first side, except that you have to waited at least 9 months from the first procedure before you can have the second procedure done. And this is just an overview of the clinical trial that was done that demonstrated that we can do this safely and effectively. It says on here 51 subjects treated. Just our own personal experience at Houston Physicians Hospital, we've now done more than that in terms of the number of patients that we've treated the second side in our own facility, and we've been able to do that with a really good amount of success. So this is really just an overview, but I do think that we've covered most of the most commonly asked questions. And now I just want to go ahead and open it up to the questions you have. And I'll just remind you kind of what Dave was saying in the beginning. Feel free to ask anything that you like. And it's almost certain that any question you might have, there's somebody else who's thinking the same thing.
Absolutely. And thank you, Dr. Bonnen. That was outstanding. And I want to encourage everybody, once again, at the bottom of your screen is a Q&A tab. So please take advantage of that. There are a couple just to get this jump started, Dr. Bonnen. Let's see. I have head and voice tremor as well. Will this treatment resolve those conditions?
That's a really good question, and it's very common that patients would have tremor that affects their head or affects their voice. And the bottom line is that we really see the most dramatic improvement with the hand and the arm, with the extremities, and we don't really plan on seeing a big change when it comes to head tremor or voice tremor. Now, anecdotally, I do have patients who believe that it really has helped with their head tremor or with their voice, but it's not something that we count on. What we're really planning on is a major improvement in the hand and in the arm. And by the way, it's less common that people would have tremor in one of their legs, but I do occasionally run into that, and we've had good success treating the lower extremities as well.
Ironically, that was the next question up was regarding leg tremors. So I believe you answered it right then and there. So thank you. Next question. Do you have to shave your head twice for the second procedure?
The short answer is yes, because by the time 9 months rolls around, uh, a patient's hair is fully grown back. And so the answer is yeah, we do have to shave the hair all over again.
Very good. Very good. Are there any different possible side effects for doing the second side? Great question.
Yeah, that's a great question. And one of the things that we didn't really talk about yet are side effects. And so that's pretty important. And regardless of whether it's the first or second side, there are some things that are more common that we would run into. So the most common side effect that patients describe to us is that they may feel unsteady on their feet. And in our experience, that's perhaps 1 out of 4, about 25% of the time. Most of the time, it's more of an awareness that they're maybe leaning a little bit to the side that we treated, and they're just not quite as steady as what they normally would be, but it's not enough that it's debilitating. And the side effects, whether it's being a little unstable on your feet or any other side effect, is typically due to some warming or heating around the area of the target. And then as that subsides and as any swelling around the target subsides in the days and weeks afterwards, then the side effects get better. So that is the most common thing that we would see. Numbness and tingling are the second most common thing. Interestingly, when people experience that, it's our experience, it's usually around the lips or the tongue on the side being treated. It's possible it could be the fingertips or the hand. That is really unusual. Sometimes people may have a little bit of difficulty with their speech, and it can be kind of insidious, meaning the patient will tell us they feel like they're having a more difficult time speaking, but sometimes it's not as obvious to us or to the family, but the patient knows they're having to work harder to get the words out. That again is not real common, but it can happen and does typically subside as the days and the weeks go by. Another thing that people will describe to us is that their ability to do controlled and very slow, methodical, detailed movements is much better. But to do really quick, rapid, nimble movements, like playing a piano, for example, may be a little bit more difficult and not better afterwards. And that's something that again will typically improve with time. But it's a nuance, if you will, that some people, if they're used to doing a lot of rapid fine motor skills, may notice. So those are really the most commonly encountered side effects. And some people may not have any of them, or you might have one or some combination, but it's typically from swelling or warming around the target zone, and then it improves as the time goes by.
Very nice. I'm going to consolidate this and kind of jump ahead with a question that goes right along with perhaps second side bilateral if a patient presents that way. How do you decide what side to do first?
Yeah, really good question. And it's just really practical. And that is working with the patient to just talk about, hey, which side is going to give you the most relief or the most benefit? So, as you can imagine, if both sides are equally affected, then if the patient's right-handed, we're going to do the right side. If they're left-handed, we'll do the left side. Now, there are times when somebody might be more severely affected in their non-dominant side, and they may say, this isn't my dominant side, but my dominant side's not very bad. My non-dominant side's really bad, and they just may choose to have the non-dominant side done because that's what is going to give them the most benefit. But it's just a really practical determination of which side's giving you the most trouble, and that's the one that we'll do first.
Right. Two-part anatomical question for you. Are there two VIM thalamus in the brain like there are with hypothalamus, followed by how big is the VIM hypothalamus? What happens with burned out, quote, or end quote, dead tissue?
Yeah. So there's a right and a left side. And so I think that speaks to the question. So you just like you have a right arm and a left arm, you've got a right thalamus and a left thalamus. And that's what we're targeting when we do the respective sides, and we do one at a time. In terms of what happens with the tissue, there's a very small area that we're targeting. It's about the size of a pea, and it's a relay station in the brain. So it's a group of cells, and those cells will be knocked out or ablated by the heat. And it's really interesting that in many cases, if you do an MRI on that person many months or a year or more later, you may not even be able to see any loss of tissue or volume loss, even though the patient's symptoms are a lot better. And then there are other times when you can actually see the little uh, dark area where there is a loss of tissue where the target is located. But it tends to vary from one person to another in terms of what it looks like on an imaging study months or years after the treatment is done.
Very good. And that really goes right along with the next question about, and I think you just addressed it, is, what could be temporary or moderate type adverse effects about uh, damaged damaged tissue to neighboring parts of the brain, and what functions do they have?
Yeah, that's a really good question. So basically, it's a really sensitive, important part of the brain where there's or what I would describe as, high-priced real estate, if you will. There's a lot of important things that are in the neighborhood. And when we talked a little bit about side effects, that is really the best way to think about what functions are around. So the reason that you would be a little unsteady or have some numbness or tingling is precisely because those are the functions that are adjacent to the target zone and that could be affected by it. So that is the best way I can explain it is that those are the things that we would be concerned about. So numbness, tingling, a little bit of clumsiness or awkwardness on the side that we treated. And so if that's in the hand, for example, that would be where the rapid, quick, fine motor skills are not quite as good. If it's in the leg, that's where you'd feel a little bit unsteady on your feet. Um, but otherwise, we don't really run into a lot of other problems. It doesn't affect cognition. We get that question a lot. Could this cause memory problems or things of this nature? And the answer is no. We don't find that it really helps or hurts memory. As a completely unrelated aside, the technology is being used to break down the blood-brain barrier and then administer medications that could be helpful with Alzheimer's. So there's some really interesting work that's being done to use focused ultrasound in a different way to try to treat patients that are suffering from dementia. But in and of itself, this doesn't affect cognition or other types of neurologic function.
Right. And again, I'm going to couple right there with this additional question. Again, going second side, are the side effects enhanced? And in particular, an individual with regards to his taste from the first side appeared to be mildly affected. Could this individual expect the same thing, but going the contralateral side?
Yeah, that's a good question. And so the short answer is that it certainly could happen when you have the second side done, but it doesn't mean automatically that it would. So is it possible? Yes. Is it certain that that would be the case? No, not necessarily. And with that feedback, the target might be slightly adjusted for the second procedure to go a little bit more anterior, which is probably more detailed than what you would want to know. But it is still possible you could experience that with the second side. Obviously, be on the other side of the lips or tongue, and it could affect taste, but not necessarily. It doesn't mean it would automatically happen the second time.
Very good. I just wanted to pause for a quick second and just let everybody know as far as timing and with respect to schedules, we're going to go another 10 plus minutes. And again, I encourage the questions that you have all asked. They've been great ones. So just a heads up in that regard. Next question, Dr. Bonnen. What is the process to determine if you are qualified for this procedure? And maybe that goes back to your particular qualifications um, and through your office and staff.
Sure. So when someone is interested in this type of treatment, they can certainly reach out directly to our office. That's no problem at all. Or they might be referred by a physician. And then it's not any different than being evaluated for any other form of treatment where we'll want to get some history, medical, background and information about how long you've had this, what kind of treatments you've had, what other medical problems you've had in the past, what type of medications you're on. So we'll get a medical history about your tremor, but then also about the rest of your broader medical history. We will want to assess the tremor, and there's some tools that we can do that help us to more objectively quantitate the severity of the tremor. And then, of course, with a movement disorder, there's the old saying, a picture is worth 1,000 words. So if we can see you in person or look at a video, it really does tell the story when it comes to tremor very quickly. And at that point, we can generally make a pretty good determination of, okay, well, is this somebody that stands to benefit from having this treatment done? And then at that point, we would start looking at, well, you know, what is the skull density ratio? We do a head CT to make sure that the focused ultrasound will be efficient and effective in terms of being able to perform the procedure. We look at insurance to make sure that under whatever their plan is, it's covered, and any cost share that they may have is accounted for. And then we work on scheduling.
Very good. And this really complements the question to follow and with regards to your wait time to see you. Do you take both, obviously, in-person visits, but also virtual?
Yeah, I would say that about half of our patients we see now virtually. And the reason is that so many of them simply aren't from the Houston area. And we've got quite a few patients from other states. And then, of course, Texas is a really big state. So if they're coming from a different part of the state, that's like being from another state in other parts of the country. So we try to make it as efficient as we can. And for folks that don't live close to our office or within the greater, Houston area, we can handle everything other than the treatment itself remotely. So the preoperative assessment can be done virtually, and then follow-ups after the patient goes back home can also be done remotely. So you don't have to travel back to Houston.
Great. Thank you. Excellent question forthcoming here. Once you have the procedure, do you go off your medication? Number one, currently this individual cites Parkinson's disease, so I'll let you handle that response.
Yeah, so that's a really common question. And basically, it again is just a really practical question as to what is going to do the best at controlling the patient's symptoms. And so, in the case of essential tremor, from my standpoint, there are a couple reasons why we would consider stopping the medication. And then there's some reasons why a patient might want to consider continuing on the medication. So, first of all, if the medication wasn't really working very well to begin with, then that, from my standpoint, is a reason not to necessarily continue taking it, regardless of the procedure. And then the second is if the tremor is dramatically better, you may not need to take it. However, sometimes patients have really bad tremor on both sides. So let's say we've treated one side but not the other. If the medicine's helping the untreated side, they may choose to continue taking the medication at least until we've treated the second side. But that's really just a quality of life decision. It's not for any other reason other than they still have tremor that hasn't been treated with focused ultrasound or anything other than the medicine on the opposite side. The second issue with essential tremor patients is that on occasion, people may be on a type of medication, specifically a beta blocker like propranolol, where they're taking it not only for the tremor, but to manage their blood pressure. And so, even though you might not need to take it anymore for your tremor, if your doctor has you taking it for a different reason, like you have high blood pressure or some cardiac condition, then we can't just stop it because even though you don't need it for the tremor, it may still be important for you to take it for your blood pressure or your heart. So that's the other consideration that we sometimes have. Now, Parkinson's is a bit different. And the reason is that patients definitely suffer in not all, but many cases with severe tremor when they have Parkinson's, but they also have other symptoms. So rigidity, a loss of motor skills or coordination, difficulty with gait and balance. And those are things that wouldn't necessarily be improved with the focused ultrasound. The tremor can get a whole lot better, and the rigidity may be better, but in some cases, the patients still really benefit from continuing to take their Parkinson's medicine, not so much to treat the tremor, but to treat the other symptoms of Parkinson's besides tremor.
Very good. Another anatomical piece. Could a side effect extend to the sciatic nerve that causes the trembling you mentioned?
So I just want to make sure I understand the question. Could a
Yes.
side effect of the treatment extend to the sciatic nerve or
Correct.
side?
Yes, that was my interpretation.
Yeah, so the treatment itself wouldn't have any bearing on the sciatic nerve for better or for worse. So it wouldn't make it better and it wouldn't make it worse. The only correlation I can really think of off the top of my head is pain is one of those things that will make tremor worse. So we know that fatigue, if people haven't slept much, anxiety, stress, those things will make tremor worse. Caffeine can make tremor worse. And if somebody's really hurting, it can make their tremor worse. So there can be an effect, but not from the procedure itself, but rather from the circumstances a person finds himself in. It can exacerbate their tremor.
Right. Thank you. Two-part question. Uh, if I have this treatment, is it permanent or could a tremor return? And if so, can you touch it up?
Yeah, so the answer to the second question is yes, you can have this treatment repeated. So that is definitely not a problem. Now, in terms of the tremor returning, it can definitely return. And I think that we actually have a reasonably good idea of what that may look like because we have been doing thalamotomies for decades now, and this is a different technology that allows us to do it in a much less invasive, more elegant, and even safer fashion. But nonetheless, the final result is very comparable to what we used to do the old fashioned way. And so, what you would see is that as the years go by, and I would say think of it in 5 year increments, 5 years, 10 years, 15, 20, 25 years, there at each increment in time is going to be a little bit higher percent of patients that are experiencing some recurrence. And there'll be a little bit higher percent of patients that the recurrence is enough to begin to bother them and is not just a minor recurrence that's much less than what it was before. So if you follow people out 20 or 25 years, the incidence or the rate of the patients starting to have recurrent tremor that's significant is going to be much higher than if you look at it at, say, 5 or 10 years afterwards. So that's kind of a long way of saying if you live long enough, eventually it probably will come back. And yes, it can be retreated. And interestingly or anecdotally, I do have one patient that had an old fashioned thalamotomy done back in I think 1994. Yeah, it was in 94. Did beautifully. It really made a big difference in their life. They were able to continue working and functioning normally. But then, roughly 28 years later, they came to see me because the tremor had returned, and we were able to treat them with focused ultrasound in the same location and with a really great result. So the original thalamotomy was not done with focused ultrasound, but it worked really well for them. And then when the tremor returned decades later and returned in a severe enough way to really interfere with their life, we were able to treat them with a focused ultrasound thalamotomy with a really good outcome. So it definitely can be repeated.
Very good. We are at the 2 minute window. One final question. You may have addressed this, but I think it's worth repeating. Post-treatment, am I able to go back to my normal and daily activities? What precautions do you advise me of?
Yeah, the only precaution that we really give patients is just to be aware that you might be a little unsteady on your feet. And the reason is you can't feel that. It's not pain. And so it would be really easy to just get up and go and not think about the fact that, hey, I could be a little bit off. And we don't want you to fall and then have an unrelated injury. So I'm not so worried that you're going to reverse or undo anything that we did. I just want to make sure that people are getting around and that they're steady and that they don't fall and have an accident. That usually doesn't happen, but it's just always better to be safe than sorry. Apart from that, we don't really have any restrictions, and people are able to travel. They can fly, they can walk, they can do all, the regular daily activities without any problem.
Very good. Well, I want to thank all of our participants. I want to thank you, Dr. Bonnen, once again for a great presentation. I think everybody, and if you could, would Sydney be able to put that information possibly up the last slide if folks needed to document last minute information on the contact front? There you go. I will tell you this, a testament to the folks at HPH, along with Dr. Bonnen's office, very tenured, very experienced, and patient first attitude, which is awesome. So thank you to all. Have a great Tuesday evening, and we'll talk soon.
All right. Thank you, Dave.
Thank you all.
Bye.